My name is Larry Bauer. I'm an expert on innovation in family medicine and primary care. I'm the founder of the Family Medicine Education Consortium, which I led from 1994 to 2021. Additionally, I'm a proud board member of Primary Care for All Americans. On behalf of the board, I'm delighted to welcome you to tonight's Teach-In, Learn-In Zoom session. Thank you for joining us this evening. With over 1,400 people from 40 states, the District of Columbia, and 350 zip codes, we are reminded of the incredible momentum we are building together to provide primary care for everyone in every American neighborhood and community. Thank you for your dedication and commitment to expanding access to primary care across the country. Now it's my great pleasure to introduce our moderator for this evening, Chioma Nwankwo, and to extend my sincere thanks to all of the presenters for tonight's event. I'd also like to thank the Primary Care for All Americans Zoom committee, as well as John Wright, Brian Kaiser, Patty Armstrong, and Liv Verde for organizing this event. Take it away, Chioma.
Hi, everyone. I'm Chioma Nwankwo. I'm from Houston, Texas, and I'm an alumnus of Ross University School of Medicine and a prospective family medicine resident. I want to start by thanking all of you for being here tonight. By joining us, you're helping to build a movement, one that focuses on providing health care to people in every neighborhood and community, primary care for all Americans. If you haven't shared your community yet, please do so in the chat so we can all see who's here as we work together to build this movement. Please continue to refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas and communities that will ultimately drive this movement forward. Before we dive into tonight's topic, we have invited one of our community members, Dennis Correa, who currently serves as the Health Center's Director for the PACE Rhode Island, to share about his personal experiences with primary care.
Good evening, everyone. Thank you for having me. My name is Dennis Correa, and I currently serve as the Health Center Director for PACE Organization of Rhode Island. PACE Organization of Rhode Island stands for the Progressive Care for the Elderly, where I oversee the operations across 4 interdisciplinary health centers that care for medically complex older adults. In my role, I work every day to reduce barriers and administrative burdens on our primary care providers. Why? Because I believe that healthcare doesn't need to be more about EHR clicks, it needs to be more about clinicians. We need more humans, more touch points, more time to actually care. Right now, too much of our system is built around paperwork instead of people. I'm a firm believer that every American deserves equitable access to primary care, and that starts with rebuilding our infrastructure, especially in low-income and historically underserved communities. I've wanted to become a doctor for as long as I could remember, but like so many others, I couldn't afford medical school. Instead, I went on to physical therapy school and later earned my MBA because those were the paths I could manage financially while supporting my family. And while I've built a career that I'm proud of, it still breaks my heart that I could not follow my original dream simply because of cost. I've been told more than once to go to the Caribbean for med school. But why should I have to uproot my life, leave my country, and take on massive debt just to serve the communities I've always wanted to care for? Our current system blocks out the very people most passionate about primary care. We are losing future physicians not because of the lack of drive or commitment, but because of the lack of access. It doesn't make sense, and it doesn't serve the needs of our country. I'm also vocal about the need for systematic change. I believe medical school should be free. Every state should be building and funding new medical schools, especially public ones, with a clear mission to produce primary care physicians. If we want more PCPs, we need to make it possible for more people to become them. We need to create pathways, not roadblocks. Until we invest in the foundation, we will keep seeing the same shortage, the same inequities, and the same preventative failures in our healthcare system. Thank you.
Wow, thank you so much, Dennis. Hearing more about what drives each of us helps this community grow. Tonight, we're here to both teach and to learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session, please. Please stay with us until the end of the session, when we'll have time for a Q&A session. We'll explore how you can help bring primary care for everyone in your own neighborhood and community. Now, it is my great pleasure to introduce our keynote speaker, Dr. Gabrielle Yarru. Gabrielle Yarru is a family medicine, public health advocate, and health equity leader dedicated to transforming healthcare access and empowering communities. A proud Afro-Indo-Caribbean woman from Queens, New York, she blends her passion for preventative medicine, advocacy, and mentorship to create lasting changes in under-resourced communities. A graduate of St. Francis Preparatory School in Fresh Meadows, New York, Dr. Yarru went on to earn her Bachelor of Arts in Biology from CUNY Brooklyn College while doing community outreach, further fueling her passion for advocacy and public health. She later pursued her Doctor of Medicine at the American University of Antigua, where she solidified her mission to address health disparities in underserved communities. With her Afro-Indian Caribbean roots, she understands the cultural perspectives on health within her community and works to build trust, access, and equity in healthcare. Dr. Yarru got involved with PC4AA as a resident and continues her work with PC4AA as Queens Project Lead. Additionally, she works in an outpatient care population health for Medicis Health Network, tackling both the social determinants of health, chronic disease prevention, and healthcare equity for underserved populations. Take it away, Gabrielle.
Thank you all for having me. All right. So I'm Dr. Gabrielle Yarru, a family physician and the Queens Project Lead, as mentioned before, for primary care for all Americans here in New York. Today, I'll be sharing strategies on how to effectively engage policymakers to advance primary care access with a focus on one of our key initiatives, the Pipeline to Medicine program. When it comes to getting policymakers on board, there's a formula that works for me, and this is it. Authentic story plus strategic framing plus actionable solution equals legislative buy-in. Too often, advocacy efforts stop at storytelling. And while our personal stories are powerful, alone, they're not enough. What makes legislators act is when we combine that story with smart framing, tying our work to the priorities they already care about, like workforce development, education, or reducing healthcare costs. Then we seal the deal by offering an actionable solution, something they can support, fund, or champion. That's how we move from a conversation to commitment. This equation is how I've been able to build partnerships with local elected officials, securing funding, launching community-based programs, and it's how all of us, whether we're physicians, students, organizers, or educators, can shape policy in our districts. As a first-generation American, born in Brooklyn, raised in Queens, my parents were new to this country, figuring out the systems and the structures on their own. I was the first child to go through the American school system from start to finish, while my older sisters were raised in Jamaica and came here later. When I decided I wanted to pursue medicine, we didn't have the connections others had. My parents weren't nurses or doctors who could help me get into a hospital to shadow or volunteer, so I created my own path. During undergrad, I was accepted into a science research program funded by the NIH, National Institute of Health, but still had no clinical exposure. I knew I needed volunteer hours to apply to medical school, so I walked into my grandmother's local primary care office in Queens and asked if I could help. That was my introduction to medicine, not through access, but through initiative. But my understanding of healthcare disparities didn't start in a clinic. I was deeply rooted in my community. I volunteered at homeless shelters and churches, taught dance, tutored students, and participated in local health fairs. The community work gave me a broader view of the social, economic, and structural issues that shape health outcomes long before someone sees a doctor. I realized that people from the community, not just in it, are essential. We need providers who understand the culture, the struggles, the languages, the nuances of the neighborhoods they serve. Because I've experienced care that could be so much better, could have been so much better if the provider had truly understood who they were serving. And that's why I'm here, not just as a physician, but as someone who's lived this journey. And that's also why policymakers listen, because I'm not asking for support in theory. I'm building what I wish I had, and they see that. So, when we strengthen primary care, we reduce downstream costs. That's a message that resonates. It's not abstract, it's fiscally responsible. Managing chronic illnesses in the clinic is far cheaper than treating strokes, kidney failure, or diabetic complications in the hospital. The data is clear. Every dollar invested in primary care saves multiple dollars in future healthcare spending. When people have access to regular care, they stay out of the ER. This hits home in the community where I work. Our local safety net hospital often faces criticism for long emergency wait times, something our local elected officials often hear about. So when I explain that expanding primary care access relieves pressures on ERs and gets people care before a crisis, it clicks. They see it as solving a real issue their constituents complain about. Trust is the foundation of effective healthcare. When people see themselves in their providers, when care is culturally aligned and community-based, they engage, they show up, they follow through, and that's how we move from reactive crisis care to preventive, community-rooted care. And that's not just good medicine, it's good politics. So here we have a chart with health professional shortage areas. And we have some comparison with other states as well. You can see New York has a total of 549. I don't have the values for California, but I believe it was estimated to be around 1,700 health professional shortage areas. When we meet with policymakers, we can't just bring passion, we have to bring proof. And that's why data is so powerful. Nationwide, around 78 million people live in primary care shortage areas. We're short over 13,000 primary care practitioners, and New York alone has 549 designated health professional shortage areas, and many of them right here in Queens. The mass majority are facility-based, clinics, FQHCs, community health centers, but population groups and entire geographic regions are also affected. This isn't just a health issue, it's a system capacity issue, it's a budget issue, it's a workforce issue, and it's one that's hurting our communities every day. People wait months to see a doctor or go to the ER to something that could have been handled, for something that could have been handled in a clinic. That's why I created this pipeline program, to meet the need from the inside out. When I sit down with a policymaker, I share the numbers, the narrative, and because when they see the data and hear the story, they understand the urgency and they act. So now to our scalable solution, the Pipeline to Medicine program. It's community-rooted response to primary care shortage here in New York. While we continue to advocate for broader policy solutions like student debt relief, salary reform, and affordable housing for physicians, we must also grow the pipeline of future doctors now. This program was inspired by my own experience, having to create my own opportunities as a student with a passion for medicine, but no access. We're now creating the access for others. With the support from the New York Health Foundation, we've launched this pilot in Queens. Students are paired with physicians at their local hospitals, gaining meaningful shadowing experiences and public health exposure. Each student is also required to present on local health disparities at community centers or health fairs, engaging early in both medicine and advocacy. This program isn't just about shadowing, it's about retention. It's about showing students and residents the power they have to make an impact right where they train. Our goal is that some will stay or return, having seen what's possible. And for policymakers, this program hits multiple priorities: education, healthcare, and workforce development. It allows elected officials to say they supported a program that's increasing the number of doctors in their district. Doctors who look like, live in, and understand their communities. It's a win for the system, a win for equity, and a clear investment in the future of primary care. Some of these local leaders listed here were instrumental in helping us secure the grant, namely Senator Leroy Comrie, as well as the Queensborough President, Donovan Richards. After I shared my personal story, outlined the community need, and presented the data, each of them provided a letter of support. Sorry, the two mentioned provided a letter of support to help us win the funding. Once I received the grant, I returned to them and other politicians with a clear structure for the program and a new request, a letter of commendation for each participating student. This letter would recognize the student's service and educational achievement throughout their engagement in the program. But we also wanted to go a step further. I offered the option for students to publish a brief piece in their office newsletter, a community health spotlight written by a student for the community. These leaders were especially excited about this idea. It allowed them to support education, health literacy, and youth empowerment all at once. For students, it's resume and CV building, real-world recognition from an elected official. For policymakers, it's a meaningful way to connect the young constituents and show commitment to both education and health equity. And for the community, it's health information written by someone who understands their experience, shared in a trusted space. It ends up being a win on all fronts. So back to the engagement equation. An authentic story plus strategic framing plus actionable solution equals legislative buy-in. That's been the formula behind our success so far. I didn't just show up with a problem, I showed up with a lived experience, backed by the data that we showed, and paired with a solution that benefits the community and aligns with the policymakers' priorities. And here's what's even more important. When we frame our work around shared outcomes, we create a space for bipartisan support. Because improving primary care access, educating youth, and reducing ER overuse isn't a partisan issue, it's a people issue. Advocacy isn't just about testifying at City Hall, it starts with relationships. If you're doing the work in your community, you have a right to bring it to your representative's attention. Start by making an introduction, sharing your story, offering your expertise. When the next healthcare bill comes across their desk, you want to be the person they think of. I invite all of us to keep using this engagement model. Your voice, your story, your program can shape policy when it's positioned strategically. Let's continue building partnerships that are rooted in evidence, powered by purpose, and grounded in community. Here, you can see on the left, we had a recent publication in a local Queens newspaper at a volunteer recruitment event for one of the hospitals that we have started this program with. And we invited one of the local politicians, Assemblyman Khalil Anderson, to visit the volunteer recruitment event where we had one of the students that are participating in the pilot program to be there present. While he was there, we spoke about the program, but we also tied it back to primary care, and being able to quote the data as stated before perked up his ears. And it was a point that, when I did contact him again later on in the week, he remembered who I was. He remembered what the problem was, and he wanted to be actionable about our efforts around primary care. On the right, you can see I'm in conversation with Queensborough President Donovan Richards about the future of this program. We discussed the idea of hosting a student-led health fair where participants can present what they've learned. He expressed interest and suggested I continue the conversation with his deputy borough president, Ebony Young, as we explore opportunities to deepen the program's community impact. So, as stated before, once we implement this equation and contact our leaders, we're able to then move forward with the whole premise of advancing primary care. Thank you.
Wow. Gabrielle, I mean, I hope you see everyone clapping for you because this is such great, amazing work. I hope you feel that coming back to you. I told you as we were prepping, I was really excited to hear about this because, as you mentioned, you've been doing this with us for a year and a half. You actually were here before I was. And so it's amazing to see what you have done. Congratulations, being bold, following up with people, or as we like to call it, nudging, and making sure that we are moving the needle in this work that's happening here. We will have time for questions in just a few moments. Drop them in the chat. We'd love to hear from you. We'll be doing that in just a second. I think you hit on some really amazing things around building buy-in with your authentic story, strategic framing, actionable solution, right? And in those key areas of education, health, and workforce development. As you are going in to talk to political or other leaders, right? And I mentioned some boldness. What is your hook? What is your thing like that you're going in with, or your question you ask to really get their interest started?
I think what I found with all the politicians is that I'm from the community. That has been their thing, having a physician. And I feel like often enough, we don't really return to our community, which is the premise of the program, to make sure that people return and increase the pipeline. But that has always been the thing because they want to hear from their constituents. They want to know what's actually happening on the ground. And then to have the expertise as a physician to say, okay, this is my vantage point and this is what I see in the office. And this is the thing that will help out, as far as the solution goes. That has been the running theme for them. They always anchor on, wow, you're from here. So they want to hear from you. They want to hear from their constituents.
I think that's really important. You're really balancing because at the same time you're saying, you also have the data, the knowledge, right? So it's that character of I am this person, this is my lived experience. And also here's the data that's really supporting the narrative that you are giving them. And I think that's a really smart move and a really great way to be moving forward. So what do you ask of them? Like when you have that conversation, what is the first information you're looking to pull in from them?
So my ask is usually, I show them the disparity, like I said before. I recognize how it impacts both the health outcomes and and I also highlight the systemic cost as well. And my ask is depending on what I need for that day, so the ask is usually for support, obviously coupled with the data, but they're usually on board once you can then go ahead and say, like, this is what people are dealing with currently.
No, I think that makes a lot of sense, especially hearing recently. I don't think in the past few years and probably way before that there's been a lot of discussion about the importance of having a PCP, preventative care. All of those things have been sort of quiet and people don't realize it. There might be a little bit more of an appetite to talk about it right now, given the current climate and the questions around like Medicaid and all of those things. People are at least heightened to awareness. So as we capitalize on sort of that wave of conversation, how can we help our legislature understand how they help provide primary care to everyone? When we look at Washington, we don't see them really directly addressing it. So what are some of those key data points that you really see resonate with the legislature or leadership as you're talking to them?
So when speaking with them specifically, I highlight the communities that they're servicing. I definitely highlight the disparities, the complaints that they always hear about the system in terms of the long wait times, different things like that, which they resonate with. But then I bring to them the actual data for New York in terms of healthcare spending. It's around 3 to 7%. I also then educate them about, well, if we were able to double this is what we can do. And that will help to alleviate this need. And I don't know if I'm answering your question correctly or if I answered all of it, but that's basically my hook usually. And the thing is, what we have to realize is we know a lot more about this side of things than they do, from a personal perspective, having been in the community, working in the community, seeing these things day to day. And, when they go to then lobby and then they go to then speak on different bills, etc., they are then armed with this information that we've just now given them. And what I've found is they usually look it up too. They'll be like, okay, what is that? They'll ask for an email so they can then do further research so they can then support. And I try to usually follow up afterwards just to say, hey, this is what we spoke about. Just to remind you, this is what's currently in the legislator, just a little blurb. And it's giving them the knowledge, allowing them to be armed with something, an area that they're not necessarily the expert in. So when they go and they're now talking to their fellow assembly persons, senators, etc., they can now come with this.
Yeah, I think one of the things you mentioned in your presentation was you got a couple of leaders to buy in, and then you were able to leverage that to then get more leaders to then buy in to other portions of the project, right? They were more willing to listen or whatever it was. So for everyone who's here on this call, we're not here because we were bored on a Tuesday night. We want to take action, right? So if everyone here wanted to do something, go talk to a legislator, who would be that next person? I know one thing you mentioned is do your research, right? Find out what is that pain point in your specific community. And then is there a way to find the right person connected to that pain point, or sort of that strategy? Can you explain that a little bit more?
Yeah, so a lot of the politicians, I didn't necessarily know what their agenda is while they were in office. And so, as you mentioned before, once I got the buy-in from this Senator Comrie as well as the president of the borough, that helped to get buy-in from everyone else. Because if they're doing it, why wouldn't I want to be on board? But through that, I found out what each politician's agenda was for the year. So for, I think, two of them, Assemblywoman Heinzman and there's another one I'm blanking on right now, education is their thing. So this was a great way to say, yeah, you're intervening on education, but this is also affecting primary care. So it's a double whammy. It's a win for you and a win for me. And how I found these people outside of the two people I initially spoke with, the Queensborough president as well as Senator Comrie, just looking for who serves my district, just looking in your area, who serves the district of, actually not just my district, but the hospital. So that way I can then speak to those persons and tell them this is what's going on and tell them what I've seen. And this is what we want to intervene on. And I've done that for both hospitals because I didn't mention before, we have two hospitals. So one hospital we're piloting right now. We're waiting for to start at the next hospital, hopefully soon. So it was me trying to figure out, okay, who's running this district and who's running the other district.
It's amazing. And I appreciate it so much. Just the layering of that local and data, the layering of the approach between education, health, and workforce development. I mean, I don't know any legislator who's not working in one of those key areas. And really, when you give them this gift of here's something you can do that'll address one or more of those things, I think, marrying all of those things in balance. Thank you so much for your presentation. Michael?
Thank you. Thank you. Thank you. Thank you. Gabrielle, you give me hope. This is just amazing work. And what's hard for people to understand, I'm in a privileged position. I get to talk to and work with Gabrielle and her team a little bit. But I also get to see other things that are happening around the country. I'm sitting in Washington tonight, just down the street from the White House at a meeting of the Primary Care Collaborative. But I'm not really here to learn about what Congress and the president are up to today, because that changes so much from one day to the next. I'm here and I'm honored to be able to be speaking on a panel that's actually moderated by Karen Johnson, who's on this call. And I'm really here to tell people and everybody, remind everybody that as amazing as Gabrielle's work is, it's one of the many communities that are now doing this kind of thing. To tell people the story of the people on this call, to talk about, we have Pam Kavanaugh has like 50 people working in New Bedford. Doing all sorts of things, 5 new task forces working on improving primary care in New Bedford. To talk about, I had the opportunity on the plane down to talk to a U.S. congressman from Rhode Island and tell him about the work that's been happening for 25 years in Scituate, Rhode Island, which is as far as we know, still the only community in the United States where everybody's provided access to primary medical and dental care. To talk about what's happening in Central Falls, Rhode Island, in Richmond, Virginia, where I was at a meeting a month ago where there must have been 75 pre-med students who understand things about the philosophy of medicine and healthcare that will help them be our leaders in the future. And we're going to start working to organize inside Richmond to figure out how to get primary care to everybody in Richmond. Obviously you just heard about Queens, in Fort Smith, Arkansas, and in Wichita, Kansas, and Alexandria, Virginia, starting to happen in a whole bunch of places. People in communities doing the 5 things or 10 things at once that we need to bring primary care to everybody because we're so far behind the 8 ball. This problem has been building for 40 years and has happened because it appears that nobody's in charge. And what we're seeing today is people in their communities take charge back and provide primary care to everybody. And as they do that, change the whole direction of health policy from being obsessed about how we pay for healthcare generically, which is just it's an important question, but all it is about finance, to change from finance to how we get this critical and essential service that everyone needs to everyone. And to do those 5 things by working with employers, by working with local government, by working with community health centers, by working on getting primary care practices fairly paid for the work they do, on getting more kids from our communities to health professional schools as we fight to open more slots and more schools to meet the demand. We are 40, 50, 60, I don't know, 100,000 people behind in a country that is putting out only 4,400 new primary care physicians a year. It's nuts. And we've got a whole bunch of work to catch up. But the good news is, listening to what I heard tonight and what I've seen around the country, we are moving. It's happening. It's starting to bubble up. So all I can say is bring more people. Start a local work group if you're not in one already. Join a state work group if you want to do that. Bring a friend or colleague. In fact, bring 3 friends or 5 friends or 5 colleagues or 10 colleagues. This mess, unfortunately, won't fix itself, but you can fix it when you sit down with one other person and join us as we get to work together. Thank you.
All right, so with that being said, in about 1 month, we will be meeting again. We encourage everyone to invite someone new to get involved in this movement. Please mark your calendars for our next Zoom meeting on Tuesday, July 15th, when we'll be hearing from Jonathan Bushman about pathway programs to help communities build primary care in Oklahoma. We look forward to seeing you then and there. Register on our website, www.primarycareforallamericans.org, where you can also check out our local state playbooks. Volunteer and donate to support our cause. Now, I'd like to reintroduce Lawrence Bauer, one of our board members, who will talk about how you can support primary care for all Americans and why your help, even if it's only a few dollars a month, is so important.
Thank you very much. So as a founding board member of Primary Care for All Americans, when we first started some time ago, I thought it was enough that I was giving my time and energy and my experience to the organization. And that was, a reasonable investment in helping things to become sustainable. And at one point I realized, and that's not enough. Really, if I really care about this, and I have a long career supporting family medicine and primary care, and I really want this to succeed, it's not enough just to give of my time. So I made a decision to provide a monthly investment in the organization. And I will tell you, it's not a large investment, but it is a regular investment. And it's important for two reasons. Number one, it's a certain amount of money that goes towards our upkeep and our operations. But I think even more importantly, for potential organizations that might provide us for financial support for the organization, they want to know how many people are regular contributors and are supporting the organization. And that number means something to them. And the larger that number is, the more they believe. If people are willing to put their money where their mouth is, to invest with more than just putting their feet in, so to speak, that the organization really has vitality and is sustainable. So I would encourage everyone to consider some level of regular monthly gift. You can go to the website. It's really quite easy to set up and to take care of, and it just takes care of itself. So, Chioma, I'm going to turn things back over to you.
All righty. Thank you so much for joining us tonight. We appreciate every single one of you for helping spread this movement across our nation in order to get the change that you deserve. All right, so please take a moment to complete our Please take a moment to complete our survey. It'll be provided in the chat. If you would like to talk with members of our leadership team, please stay on the call, and our board members of PC4AA will stay to hear your feedback to help us grow as a community. Thank you so much, everyone, and we will see you on Tuesday, July 15th.
Thank you guys so much. And as Gabrielle is also answering some of the questions that are popping in the chat, we do have a few minutes that we can talk through some additional questions that people may have. Jay, are you on the call still? Are you able to hop off mute? Because I know you had a couple of quick questions. And
Yes.
Wonderful. Did you want to ask directly to Gabrielle some of the things that you were thinking?
Yes. Dr. Yarru, it was wonderful to hear your presentation and very encouraging the way you have actually, carried through this, the whole initiative. Now I think different states, different areas, everybody is trying to do their own, own bit. And it kind of varies from place to place, person to person, given the pressures they are under. How can we as an organization support this at a more national level, where maybe the research that you do for New York, all of these information is available in the Bureau of Labor Statistics, I believe, right? BLS.gov. So you can find that data from there. So if somebody wants to do this in Texas, for example, we can pull the data for Texas and give it to them, or for their metropolitan statistical area, whichever they want to do. So we give them the data. We have a template for maybe a presentation where, okay, you need to hit this, this, and this in order to get their attention, because not everybody is good at getting the points through across, having that specific communication. People have very little time. So how do we create, I know we have playbooks, but how do we create this in a manner where the advocacy becomes more pointed, more effective? I guess that's my question.
So your question is how to get the advocacy more effective around increasing the pipeline programs, or are you talking about just primary care pipeline programs?
No, primary care first and then pipeline as well. The pipeline is obviously going to be important, because without it, the future looks bleak, actually.
I think what we're doing now in creating all these work groups is what's effective as well. We're getting the knowledge from everyone all together, what they're doing and what they're seeing in other states. But also creating the local work groups, as said before, getting key stakeholders, if you want to say. So CBOs, faith-based organizations, the people who are actually in the community to gather together to say this is what the problem is. After that, then we can work to build the playbook. I know you said we have a playbook already, but I believe that the playbook and having a way that we can all move forward together, highlighting that this is an issue, not just only in Queens, but this is an issue. Um, let's say, for example, we have Rhode Island with their primary care report. And then we can say that, these are the solutions that we have for now. It's not only the educational part, it's also, like I said before, increasing funding within primary care, being able to double it if we are able to do so, etc. I don't know if I fully answered your question.
No. I mean, this is something we are all evolving as a group. So
Right.
I'm just trying to see how to build a structure around it so it becomes easier. And people, because when we create local work groups, everybody say yes, and then because I think there is a lack of how to go about maybe taking the next step, it kind of tends to stagnate for a bit. So I'm just trying to see how to, okay, we have done the step 1, step 2, step 3, step 4, and let's just move forward. That may become a little bit easier. That's what I'm thinking.
Yes.
Pam,
Sorry.
if I may interrupt, maybe we can ask Pam Cavanaugh to come on and talk about the steps that she has taken in New Bedford to build a local work group now of about 50 people.
Okay.
Yes, when I started to gather the names for the local work group was about September. I had 10 contact people. Now, I've worked in the community at a community health center for 38 years, and I had dealings through my career with many of them. So they knew me and they trusted me. So in bringing them on, these 10, we did what Michael said, invite somebody else that would be interested in participating in this group in New Bedford, Massachusetts. And before I knew it, over several months, we had grown to about 50 in our full work group. And from that 50, we had developed a work plan, a 5-year work plan. And now what we've done is break down the work plan and those 50 members into 5 task forces. So whatever their interest was, is what they chose as a task force. And they're working on different parts of the work plan. And that's how we've been evolving and going forward. We've produced a New Bedford primary care report with data collected from our 3 collaborative health organizations in the area, one being the community health center where I worked, and the other is another medical practice, and then South Coast Hospital. And those 3 groups have worked together. It's been amazing to gather data on how they are delivering primary care in the area. So, we're always evolving going forward. It's really very difficult to have a structured format for every community and for every state. They're all going to be different. So what works in New Bedford works in New Bedford. It may be able to be replicated in Austin, Texas, in parts, and it may not. So it really depends on the community and who do you bring to the table for discussions.
But
Got
if I can jump in just for a second, I mean, inviting the right people, inviting people, and is critical. Meeting regularly is critical. So, we meet every 2 weeks, or did in the beginning for sure, and before we broke into task forces. Choosing winnable battles, doing something you can achieve. So the first winnable battle in New Bedford was creating the primary care report. And before long, we had something we could show everybody. Everybody could touch and feel that made the challenge real. The pipeline program that you're hearing about in Queens is something that's a real, achievable, winnable battle. So choosing winnable battles, the community organizer in me says, choose a winnable battle. Um, sort of have the battle, win, and then have a big party, feed everybody, and start again. It's an iterative process at the end of the day, but it really depends on having people come to the table and bring them back and give them something that they can sort of get their hands around and help with, and then succeed with.
I think this is a really great conversation. I'm so glad that we record these because these are the things that we are trying to accomplish, right? How to create overlying structure with localized implementation, right? And I think, Jay, that's sort of what you were kind of talking about is what are so sort of overarching things that we need to do. We need to identify critical local need to reach primary care access, right? We've got to get everyone access to PCP care. How that happens in each local community will be unique and different. I think tonight, especially, Dennis, I know, talked some about this in his world. Dennis, I've seen you in the chat a little bit here asking about state funded medical schools and things like that. I don't want to steal your words, but do you want to come off mute? And thank you so much for your presentation as well today. If people have questions for Dennis and he's still on, feel free to pop those in the chat as well.
Yeah, thanks, Patty. A lot of times I think of, like Rhode Island's a small state, and I always wish we were like a pilot state because we have so many opportunities, small but large state, and we have an opportunity to have a second med school in Rhode Island, and I think it is key. You know, um, I think we need as many med schools as possible to feed into that pipeline. You have a shortage. I mean, I think on average, they're saying in the next few years we'll be short 44,000 PCPs. And I don't want to ever think that AI is going to replace that. Harvard Business School a few years ago released a program that they wanted to have patients take a survey in the morning that would bump you in the queue line of who needed to be seen by a PCP. And I don't want AI to replace anybody. I just want us to think of our workforce shortage and where we need to replace them. I'm also very privileged to work with amazing nurse practitioners on a daily basis, and they've been forced into a role to be PCPs, and nor do they have the education for it. And I don't think there really is some pipelines for them also to further their education, what's there. And I would love to hear the group's thoughts on how, one, we can support more state schools, and two, how do we support our nurse practitioner colleagues in the fields who've been thrown in at state levels to be PCPs.
Gabby, do you want to take that one or Michael?
I will leave that to Michael because I think he has a little bit more expertise than I do in this.
Well, I mean, I think this is a process of organizing. So, in Rhode Island, we now have a state Senate study commission on building a new public primary care medical school for the state of Rhode Island. I can't promise that it'll get across the line, but we're making huge progress. And that's because of everybody working together, and advocating, particularly in the Rhode Island State Work Group, where we do a fair amount of work on that issue and go to the I was at the legislature twice in the last week to testify about that and some other things. I was actually there 3 times now that I think about it. We're going to be testifying again on Thursday. So it's showing up and helping people understand the problem and what the solutions are. We need, and I'm glad you brought up residencies because we need lots of new residencies as we need medical schools Because if you have medical schools and no new residencies, you haven't accomplished what you want to accomplish. So we need new residencies in family medicine, in pediatrics. If we could find people to do general internal medicine and general internal medicine, but also for nurse practitioners and PAs to give them an equal shot at the practice. They need more training to be able to practice in the way that we're asking them to practice. So lots of opportunities, but it depends a lot on people being organized and my favorite word, and nudging not just each other, but nudging their legislators, who generally won't do anything unless they have to.
Brian, I see your hand raised.
I don't have a question and I don't have an answer for Dennis. I'm sorry, but I wanted to just say to Dennis how much I appreciate what you shared tonight. I think your story is inspiring. I think the world is a worse place because you are not a primary care doctor, which you want to be, and you would clearly be a great one. And I am so impressed that you have taken that passion and still directed it toward helping people. And so thank you very much for sharing your story.
Thanks, Brian, for sharing that. I think, part of the encouragement of this group is coming together, right? And it's an amazing thing as you build a movement. It's not just the time that we put in together. It is the encouragement, it's the locking arms, it is that financial support that Larry talked about, right? Because as much as I would love words of affirmation to keep this movement going forward, it also takes dollars, right? And so just to continue to encourage you to consider what your involvement is. We do have the survey. If you haven't had a chance to complete that survey yet, I will drop it in the chat once more, because we do look at these pieces to see, what are other things that we should be learning and sharing about during these times that we have together. So thank you guys so much. I don't see any more questions in the chat right now. Judith, I don't know if she's still on. She said she had to slip out, but she said she presented at Tufts Medical School Primary Care Conference and put PC4AA with a link on her slide, what you can do to ensure access to primary care for all. So again, there are ways that we can continue to share what's going on. Our next meeting will be on July 15th, and so we hope to see you all there. Michael, any additional send-off words for everyone?
Nothing other than please find somebody else and get started. It's just, I am in a hugely privileged position because I get to see everybody working together in ways that nobody else gets to see everybody. It's the most gratifying and exciting work that I think I've ever seen. And it's clear to me that we can make this happen. It's a long road. And it's not an easy road. But if we don't start, there's no way to get there. And, look to your left and look to your right, because the people who are going to make a healthcare system for the United States are the people who are on this call together tonight. Thank you all.